Your Excellency دكتور هلال الساير, دكتور قيس دويري, حضورنا الكريم, thank you again for making it today. We have people coming in. If we can I would like to welcome to the stage for opening remarks KFAS Deputy Director General for Support Functions and Programs, Dr. Amani Al-Bidah.
Good morning, everybody. I won't be long today. I just wanted to say a few words about why we do what we do and remind ourselves of our long-term mission and plans. The value of knowledge and research is that at the rudimentary level to satisfy a sense of wonder, but at a more elevated level is to navigate the physical, spiritual, and social worlds. Navigating the physical world means that we understand, manipulate, and sustain nature, but navigating the social world means that we create a common language that makes this understanding available in everyday decision. We give this a fancy word or name today, which is evidence-based decision-making or policy-making. And this is what we're talking about today. For this to work, evidence has better be of good quality. The research has to be of comparable quality to international standards. The translation of this evidence has to be in a language that is common enough for us to benefit from other societies' experiences and to share with different levels in society. Along these lines, KFAS works at several levels to ensure that we are in fact building this culture that adopts and understands and manipulates and sustains all the sustainability goals. For one, supporting research to understand and manipulate a huge national problem at hand, this is diabetes. At a different level, we collaborate with centers of excellence in the world to ensure not only that the caliber of research is what we expect it to be, but also that the language we're building is common international language that enables us to benefit from other societies' experience and not to be trapped within our little box. At a third level, we support, at a social level, the creation of a social understanding of the problem, of the potential solutions, and enables us to adopt at the level of policy and at the level of social dialogue, even at the level of the individual. In the special case of diabetes, KFAS established the Dasman Center for Diabetes to take on the proactive role in creating the relevant understanding and common language and to enable innovation at the level of physical treatment of the disease and the social policies that ensure the sustainability of public health and public resources. I would like to thank our panelists for accepting the invitation to talk today. We would like to learn from their experiences, from their interactions, from their research, how we should better think about the policies relevant to minimizing or limiting or controlling the spread of diabetes. I have heard many success stories that we never shared. We never had the opportunity or the forum to sit and talk about them in a public debate. And I hope that we learn from each other today enough to enforce the policy making at the highest level in Kuwait. Thank you.
Thank you, Dr. Amani. So we have two sessions today, one starting now and then our second session starting after a coffee break at 11:15. Our first session, we are pleased to have with us today from the London School of Economics, Dr. Zlatko Nikolowski. Him and Dr. Fahad Al-Mulla are co-principal investigators or principal co-PIs in the research that is commissioned by KFAS on estimating the burden of diabetes in Kuwait. Dr. Zlatko will be speaking for 45 minutes and then we will move on directly to a discussion panel. And again, I reiterate Dr. Amani's gratitude to our panelists who agreed to participate with us today. That panel will be moderated by Dr. Fahad. So I call on Dr. Zlatko to please come to stage and join us and present.
Good morning, everyone. So my name is Zlatko Nikolowski. Thanks. And I'll present some preliminary findings on our project, which is currently ongoing and which deals with estimating of the burden of diabetes in Kuwait. So as I said, this is still an ongoing project. So I'll just introduce the literature review, which we've just finished. I'll present a bit on the methodological approach and the preliminary results of the project as well. So just to give you a background, diabetes affects about 387 million people globally, and it is also a significant problem in the Middle East and North Africa region as well. According to the ongoing research in 2015, about 35.4 million people in the wider MENA region have been diagnosed with diabetes, and according to the projections by 2040, it's expected that this number will double to about 72 million people if nothing is to be done about reduction of the new diagnosis. So clearly, this means that this is a significant burden in the wider region. Given the fact that the MENA region is quite heterogeneous in terms of countries, level of development of various countries, we see a different prevalence of diabetes across the region. So it's, according to recent estimates, the lowest prevalence of diabetes is registered in Egypt with 7.2% of the population, and the highest in Saudi Arabia. The estimates there range from about 22% to about 24%. So clearly we see that there is a pattern. The countries which are lower middle income countries such as Egypt have lower prevalence of diabetes, whereas countries which are high income countries such as Saudi Arabia have much higher prevalence of diabetes. Given the fact that Kuwait is considered as a high income country, obviously there we expect that the prevalence of diabetes to be high as well. According to our estimates based on the World Health Organization World Health Survey, about 13.9% of Kuwait nationals are diabetic. The share is much lower nationwide, and obviously that's because we include the expatriates, where the prevalence of diabetes is much lower. So against this background, this project, which we are currently working on, has a fourfold objective. First, relying on the WHO World Health Survey, which was done in 2009 but released in 2013, we have just finished the analysis on the link between the prevalence of diabetes and the most common risk factors associated with diabetes in the country. Then, based on this finding, what we're doing now is we are trying to analyze the link between diabetes and healthcare utilization, both outpatient and inpatient. And then this is again based on the WHS data. And then based on our estimates, and I'll talk about methodology in a little bit, based on our estimates, then we try to determine the total direct and indirect cost of diabetes in the country. And this is by providing a fairly static measure. So we're just looking at one point in time, obviously, given the cross-sectional nature of the survey. And then finally, this is an idea that we currently have, is to critically evaluate the existing preventative measures aiming at reducing the burden of diabetes, but also looking at comparative analysis with the rest of the Gulf region, and to see whether some of these measures could be used in some sort of simulation exercises to see by what extent, if we implement them, the burden of the disease in Kuwait can be reduced in medium to long run. So in terms of the significance of the study, there are a few important aspects that we think that the study will contribute to. Obviously, given the fact that we are academic researchers, we're hoping that this will lead to an academic publication in a good journal. However, this research is also relevant from a policy point of view, obviously. It allows to attach an unambiguous cost associated with the diabetes in the country. It could also provide as a template for studying the economic burden of other NCDs. So this is quite so this is a field which is getting a lot of traction. It's part of the United Nations Agenda 2030, one of the Sustainable Development Goals, one of the targets, I think it's target 3.4, specifically deals with the reduction of NCD, the burden of NCD. So clearly, what we're doing here can be replicated in the wider NCD spectrum of diseases. And finally, our study, we're hoping that it will contribute to the efforts of reducing the overall burden of disease in the country. We're also hoping that we can foster institutional links with the Dasman Institute, which could be continued and could lead to further research work. When we started the project, obviously we started by, just like any other research, we started by doing a literature review of the determinants or correlates of diabetes. Judging by the literature, we isolated quite a few common factors which are associated with the prevalence of the disease. Physical inactivity, family history of diabetes, poor nutrition, genetic factors, age, education status, BMI, so being overweight or obese. These are all considered as significant risk factors associated with diabetes. The literature also finds a quite interesting link between the socioeconomic status and the prevalence of diabetes. And we see that there is a different link depending on the level of development that the country is at. So in the developed countries, it is the lower socioeconomic groups where the prevalence of diabetes is higher, whereas the relationship is inverse in the low and in the middle income countries. The literature obviously stipulates because in the high income countries, those that are poorer have easier access to cheaper foods, don't have too much time to exercise and so on. So obviously this leads to higher rates of obesity and obviously higher rates of diabetes in the lower socioeconomic strata. Whereas in the low and middle income countries, obviously there is still a significant level of importance attached to conspicuous consumption, which is particularly important for the high income groups. And obviously there we see that the higher quintiles of the socioeconomic strata actually have higher prevalence of diabetes. So in terms of the literature review of diabetes in Kuwait, so we started, when we were doing the literature review, first we started by looking at sort of the broader literature, looking at the entire spectrum of high-income countries. And then we wanted to focus specifically on the MENA region, but also to focus specifically on Kuwait as well. And our results yielded quite a few interesting studies which have been done so far. The research goes back to the mid-1990s, where there was a seminal study by Abdallah et al., which found that the older and obese individuals, those that are suffering from hypertension, cholesterol, and triglycerides, as well as individuals whose parents had or have diabetes, were more likely to suffer from the disease. Similar findings are confirmed by a study by Al-Khalaf et al., which was done about 10 years later, where age, the body mass index, and family history of diabetes were also found to be strongly associated with the probability of having diabetes. In 2013, there was a very interesting nationally representative study. So this was the first one and the only one so far that we found, which was done on a nationally representative samples of individuals. And they concluded that the BMI, or rather obesity and overweight, is the most statistically significant correlate of diabetes in the country. Finally, STEPS, the WHO survey on risk factors, NCD risk factors, could also provide additional evidence on the link between diabetes and some of the most common risk factors. However, just like in the other countries in the region, here as well, STEPS is only conducted on a national, on a sample of nationals. So therefore, this could lead to an underestimate of the total burden of diabetes, but also risk factors associated with the probability of having diabetes. So that's on the literature review on the risk factors associated with diabetes. Given the fact that this is a project about cost of diabetes, we also tapped into the existing literature on how this cost is measured. So according to our findings, there are two types of costs which are associated with diabetes and with any other NCDs. First is the direct cost. And that cost stems from utilization of outpatient care, inpatient care, medications and medical devices. And this is obviously the highest share of the total burden of disease attributed to the disease. Out of the total direct cost, hospital inpatient care is actually the biggest component, about 43%. Followed by medication, which take up about 18 to 20% of the total direct cost of diabetes. And this is according to findings that were conducted in the US and the UK. In addition to the direct cost, there is also an indirect cost attached to diabetes, and the indirect cost is factored in as a productivity loss via morbidity, disability, and premature mortality. So, for example, some of the examples of the indirect cost could include, for instance, increased absenteeism of workers due to the disease, inability to work due to long-term disability, completely dropping out of the labor force, and so on. According to the estimates conducted in the high-income countries, about 10 to 20% of the total burden of diabetes is actually attributed to the indirect cost. So, while this is a lower component of the total cost, it's not negligible, obviously. So in order to come up with a full picture, the indirect cost of the diabetes has to be taken into account as well. In terms of the existing studies of burden of diabetes in the region, there were two. Well, actually, there were three. The last one we are finalizing. So with colleagues, we have conducted a study on the burden of diabetes in Qatar in 2017. So we're trying to clean that up and to see whether we can publish it in a good journal. But before our study on Qatar, there were two additional studies, one in the United Arab Emirates in 2010, and one in Saudi Arabia in 2014. So clearly there is no study on the burden of diabetes in Kuwait, and there is a need for research in this field, and hence our study. Right, so that's it in terms of the literature review on the cost of diabetes and the prevalence of diabetes and risk factors associated with diabetes. Now let's talk a little bit about the methodology and how we're planning to approach our study. In estimating the direct cost of diabetes, first we rely on estimating the probability of using both inpatient and outpatient services contingent upon having diabetes. Here we're planning to use the logic model analysis. So the equation is very straightforward. We have a dummy variable of utilization regressed on the diabetes dummy, and then a host of a battery of independent variables, including the standard socioeconomic variables, age, gender, and so on. The parameters from these estimations will then be used in order to estimate the total direct costs, provided the average cost of inpatient and outpatient healthcare services, as well as the total number of diabetics in the country. So once we have the odds ratios, once we have the parameters of this exercise, then the rest of the calculation should be a simple arithmetic. But what we are currently working on is actually finding the parameters of this equation, and I'll talk about the current findings in a second. It will be also quite useful to couple the estimation based on the WHS data with administrative data. And here, I'd like to show what we did in the case of Qatar, and to see whether, well, during the discussion, perhaps we can see to what extent this could be replicated in Kuwait using administrative data. So in the exercise with Qatar, we use both the WHS survey for Qatar, which was done in 2010, but we also used administrative data, which is actually quite good in that country, because, well, the country is fairly small, so that was one advantage. So for the inpatient direct cost, we took data from two sources. From the public provider of inpatient services called the Hamad Medical Center. We took information for each inpatient admission, which inter alia included the age, gender, nationality, the length of stay, and up to 38 diagnoses that, which were assigned to the DRG. Given that we were aimed to estimate the total direct cost of diabetes, all inpatient admissions where diabetes appeared as one of the diagnoses in these 38 were isolated, and the cost was calculated based on the respective DRG associated with the inpatient admission. Similarly, data was taken from the private providers. This is the NHIC. The only difference between the Hamad Medical Center and NHIC is that in NHIC there were data only for Qataris. The important thing is here though, to underline is that we took information for all 38 diagnoses. And the question is why taking up to 38 diagnoses? The anecdotal evidence suggests that the complications related to diabetes, rather than diabetes itself, are the main reasons for hospitalization of the diabetic patient. So this is why we didn't only take the inpatient admissions where diabetes appeared as the first or the second or the third diagnosis, but where it appeared across any of these 38 fields. So according to our estimates, and in the Qatari example, based on the HMC data, about a quarter or 24.4% of the inpatient costs were due to diabetes 2 without complications. So the majority of the cost is actually due to the complications of diabetes. And this is why, I guess, casting the net a bit wider was very important. So moving on, for the outpatient direct costs, then similarly we took data from PHCC, which is the main outpatient provider in Qatar, which encompassed all the outpatient visits in the country, but the data, unlike the inpatient visits, contains only information for up to one diagnosis. So that was one of the biggest limitations of the outpatient data, and that was also acknowledged in the study. Similarly to the literature review that I've just discussed before, our estimates on the outpatient direct cost revealed that about 55.4% of the total outpatient cost in the country was actually due to pharma products. And finally, in order to really provide a much more comprehensive picture, we took additional data for outpatient visits from the Qatar Red Crescent, particularly bearing in mind that the blue-collar workers tend to use QRCS mobile clinics quite a lot because of many reasons. Either they don't have money to go use proper healthcare, or there is a language barrier as well. So in order to really provide a comprehensive picture of the total burden of the disease in the country, we took data from the Red Crescent Society as well. And in terms of the indirect cost of diabetes, we followed a threefold analysis there. First, estimate the probability of being unemployed, conditional upon having diabetes. And then second, to estimate the productivity loss associated with diabetes. In Qatar, we use wages as proxies for productivity, and in this case as well, given the fact that the World Health Survey for Kuwait has some data for wages, we can see to what extent running t-tests and the differences between average wages of diabetics and non-diabetics by industry could also tell us a bit more about differences in productivity of these two types of workers. And then provided the results. In the Qatari experience, what we did, we assessed the productivity loss due to excess hospitalizations and excess outpatient visits, and we aim to actually use the same approach in the context of Kuwait as well. Finally, in the final part of the exercise, what we're trying to do is to critically evaluate the preventative measures towards reducing the cost associated with the type 2 diabetes. And the preliminary evidence has grouped the existing interventions into three major groups. So moving on. So in the level 1, these are cost-effective measures, and they're very easy to implement. They include glycemic control, the blood pressure control, and we can, in the WHS data, there is some information about how many patients already are taking blood pressure medications or do take insulin. So we can try to see how we can actually use the existing data that we already have in the country. Level 2 interventions are cost effective, but they're moderately feasible. Here, according to the literature review, we have found things like administrations of ACE inhibitors, smoking cessation, which is particularly important in the region, the foot and eye examination among diabetic patients, particularly given complications and amputations associated with advancement of the disease and so on. And then finally, level 3, these are the less cost-effective measures. They encompass detection of undiagnosed diabetes, intensive glycemic control. So these are, they require a bit more time and also a bit more finances in order to be implemented as well. Right, so that was, in terms of methodology, how we're planning to approach the issue and how we have dealt with a similar issue in a country in the region. So now I just want to introduce the data set that we are currently working with, as well as some preliminary findings on the first and the second objective of the project. So the data set that we are using in this particular instance is the World Health Survey for Kuwait. It's 2013. It was done in 2009, but released in 2013. It's a nationally representative survey, obviously, so it covers the entire country. It includes face-to-face structured interviews. Several body measures were carried out using blood pressure, pulse, and so on. It also has the standard socioeconomic part of the survey, so it asks participants about consumption, employment, education attainment, and so on. There are a total of 3,800 respondents. So the Kuwaitis are about 2,500, and the rest are expats. And obviously, they are weighted in order to account for their representation in the total population of the country. So the results in terms of the descriptive statistics, it's important to know that in the standard WHS, World Health Survey, there are blood samples and there are also self-reported measures of diabetes. Unfortunately, in the case of Kuwait, the blood samples were taken, this was optional. So they were taken from just a handful of respondents. So obviously, relying on those estimates would not give us a good understanding of what are the first main correlates of diabetes, and second, what is the burden of the disease attached. So this is why we have relied on subjective measure of diabetes. And I know this is not ideal, but this is the only one that we can use for the time being. So the question asked respondents, have you ever been diagnosed with diabetes? And then we've created a dummy variable, 1 if they said yes, 0 otherwise. So just as I say here in that paragraph, the low response rate in the blood measures prevented us from actually doing the standard objective measure of diabetes. So according to this self-assessed definition of diabetes, about 13% of the Kuwaiti nationals are diabetic. And as expected, like in the rest of the region, the prevalence is a bit lower among the expatriates. We see about 6.7% of the expatriates to have declared that they've been diagnosed with diabetes before. So, I don't know if you can see this. What's important to note is that this number here, we see that the prevalence of diabetes among overweight and obese is actually quite high compared to those that are underweight or normal weight. Also, the prevalence of diabetes among those that do not have any physical activity is also fairly high. In addition to that, we see that the prevalence of diabetes among those that actually have healthy blood pressure is also much lower compared to the prevalence of diabetes of those that do not have healthy blood pressure. So clearly, sorry that I didn't present this very well on the slide, but clearly here what we can see is that we already see some patterns, and we already see that some of these correlates of diabetes which appear as statistically significant correlates in the international literature. We see that we already see some patterns of the correlation between these risk factors and diabetes in the case of Kuwait as well, albeit descriptively. So now we move on to the logit model of the entire sample of the respondents. And what we did here is actually we did the logit model of prevalence of diabetes. So we've regressed the dummy variable of whether or not a respondent is diabetic or not on a host of socioeconomic variables and risk factors. So in doing that, first we included age, gender, and objective measure of socioeconomic status. Then in the second regression, what we did, we included one of the most common risk factors, and that's being obese. And then in the third regression, in order to do a further robustness check of our findings, what we did is that we included the same set of socioeconomic factors and risk factors, but we also experimented with the self-assessed socioeconomic status. The most important finding here from all three regressions actually relates to obesity. And then here we see that those that are obese are actually roughly about 1.6 times more likely to be diabetic compared to those that are of relatively normal weight. What we also see is a very statistically strong link between age and probability of having diabetes. Clearly we see, well, you can't see it very clearly because the numbers are very small, but the odds ratios in this age category, in the latest one, in the oldest people, we see that the odds ratios are roughly 20 to 22, which means that they are 20 to 22 times more likely to have diabetes compared to those that are younger. Unfortunately, we don't really find anything on the link between socioeconomic factors and diabetes, but that's probably because of some sort of multicollinearity that might be going on in the sample. I mean, we see that, for instance, the dummy for being employed or not is statistically significant with odds ratios less than 1, which means that those that are employed are actually less likely to have diabetes. So we assume that, and also those that are employed usually are at a higher socioeconomic status. So we do conjecture that some of the significance of socioeconomic variables are actually assumed by the statistical significance of the employed variable. So the main takeaway message from this logic modeling analysis here is to say that we do confirm the findings from the existing research, particularly bearing in mind that we do find a strong link between obesity and the probability of having diabetes, as well as age and the probability of having diabetes as well. As a robustness check, and you can see this much better, we have repeated the analysis on the two subsamples in the survey. So we have started first with the Kuwaiti nationals and then with the expatriates. And the findings there pretty much are the same compared to the findings in the total sample. And again, the most important finding is here at the bottom. So we see that those that are obese are actually 1.3 times more likely to have diabetes compared to those that are of normal weight. And we see that the relationship actually holds in both samples, in the Kuwaiti nationals and in the expatriates as well. So now, as I said, what we're trying to do is we try to parameterize that equation which I showed you earlier on the utilization and diabetes. We still haven't found a model which has a strong predictive power yet. So I just wanted to show you some main descriptive findings of the utilization of healthcare services based on the WHS data. So in the top panel, what we see is the utilization of inpatient and outpatient services among Kuwaiti nationals and expatriates who are self-assessed diabetic. And here is the utilization of those that are not self-assessed diabetic. Obviously, we see, or overall, we see that Kuwaiti nationals have slightly higher utilization of, who are also diabetic, have slightly higher utilization of inpatient services. And we have the same finding on the outpatient services as well. Among among the expatriates, we also see that those with diabetes have also, self-assessed diabetes have a higher utilization of outpatient services as well. So overall, the preliminary conclusions from this ongoing research so far suggest the following. As in the rest of the Gulf region, diabetes is a significant problem in Kuwait. Based on the data from the WHS, albeit subjectively assessed, the prevalence of diabetes is 13.4% among Kuwaiti nationals and about 6.7% among expatriates. The results of the logic model confirm the existing notions on the main correlates of diabetes. Age, socioeconomic standing, and obesity are the main determinants or correlates of diabetes in the country. The findings hold when the analysis is conducted on both subsamples, Kuwaiti nationals and expatriates as well. So the same set of correlates appear to be statistically significant in both instances. And preliminary evidence, and this is very descriptive still, suggests that the diabetic patients are heavier users of inpatient and outpatient healthcare services. As I said, this is still very preliminary and it's descriptive. We're still working on the logic model on utilization, and hopefully we can parameterize it very soon, and the parameters will be used in the calculations of the final burden of the diabetes. So the next steps, in terms of next steps, we are planning now to derive the odds ratios for utilizations of inpatient and outpatient services among diabetes patients. Use the odds ratios in deriving the total cost of diabetes in the country. We still have to also work a little bit on the indirect cost of diabetes. As I mentioned, this was the the differences in productivity, dropping out of the labor force as a result of the disease, and so on. However, and I would like to underline this, and perhaps we can discuss this during the discussion part, it would be ideal, as in the case of Qatar, to couple this exercise with an estimate of the direct cost based on administrative records, particularly given the fact that the data from WHS only provides subjective or self-assessed prevalence of diabetes, so it's not ideal. So in order to use administrative records, we would need admin records for inpatient episodes, including all of the diagnosis associated with that particular hospitalization. And also we would need administrative records on the outpatient visits, as well as the diagnosis associated with the outpatient visit. So that was it from my part. If there are any questions, I'd be happy to answer them. Thank you very much.
For the next hour, we're pleased to have with us 5 panelists to discuss. They will be moderated by DDI's own Chief Scientific Officer, Professor Fahad Al-Mulla, who's also a co-principal investigator in this ongoing research with Dr. Zlatko. So I want to please welcome onto the stage, and hold your applause till the end, Dr. Abdullah Sabah from Ministry of the Defense. He is the health economist and supportive of much research commissioned by KFAS. Dr. Mohammed Al-Khamis from KISR, Kuwait Institute of Scientific Research. Dr. Nail Al-Mazidi from Kuwait Diabetes Society. Dr. Hassan Kendiri from DDI. And last but not least, Dr. Abdullah Ajil from the Director of Health and Vital Statistics from the National Center of Health Information at MOH. I understand, I thank you for taking time from your very busy schedules. We have 1 hour. We hope to give everyone a fair chance. Dr. Fahad, I yield the floor to you. Thank you very much.
Thank you for being here today. We have in front of us probably 4, and should have been 5 of the most prolific people in this field. You've heard Dr. Zlatko talking. Can I have your opinion on what's going on here, really? And I would like to start with the ladies first, Dr. Nail.
Thank you, Dr. Fahad. And thank you for inviting me to this panel discussion. Coming here today, I represent a non-profit organization in Kuwait. We are Kuwait Diabetes Society. And I'm lucky to have 2 of the board members here today I'm representing, and Dr. Hassan Kendiri is our Vice President and the Treasurer. So obviously cost is very relevant to us. I'd like to address the cost burden part of diabetes in Kuwait. There is an issue in Kuwait that there are, of course, as Dr. spoke, there are many aspects of the cost burden. We have the material cost regarding the outpatient and inpatient visits, the cost of the devices, everything, the supplies that patients with diabetes need, the cost of medication. There's also the cost of, there's the psychosocial cost or the moral cost, the burden of maybe the deficiency of psychosocial support regarding this aspect, the cost that morbidity causes for patients with diabetes, leading to indirect costs, which are, as you've mentioned, a decrease in productivity and an increase in complication rate, leading to a decrease in productivity. What we strive to work for in Kuwait Diabetes Society is trying to decrease the cost, the material cost, for one, on patients. We provide glucose measuring devices, glucose strips, glucose supplies at reduced cost. So it's about 60% of the market cost in collaboration with the companies that have a contract with Kuwait Diabetes Society, and a small fee, a membership fee that we put, it's I 5 kd a year, and they would get these benefits. Regarding that, we do not, it covers most glucose supplies, most of them. We do not provide medications because we are not a healthcare organization, obviously. Regarding psychosocial or moral support, we're starting a support group for type 1 diabetes in girls during the college years, which can provide excellent psychological support for a disorder or a disease that has a huge psychosocial burden. Also we have through the implementation of diabetes camps for kids, we have that yearly. This year we're going to be holding the 5th year. Last year we are very grateful for KFAS for sponsoring it. And this also provides a good psychosocial platform for kids who are struggling to come to the terms with diabetes. From the point of view of the morbidity, we provide free retinal checks and diabetes foot checks by a doctor who comes about once a week to KDS. And by doing this, we hope to decrease we strive for early diagnosis of retinopathy and diabetic foot so that we can aim to reduce the morbidity that these two entities cause. In addition to providing all these services, the problem is that the material services, they are not provided by the Ministry of Health regarding glucose checks, checking machines and strips, so we have to help out, we have to do our role in society from that side. What we do is we do public awareness events in which we provide free glucose checks and blood pressure checks to the public. Every public awareness event we've done, we have not checked for less than 1,000 people in a 12-hour period, and we have found so many cases of newly diagnosed diabetes and referred them to the appropriate healthcare organization or healthcare center. So by this way, we aim to strive for an earlier diagnosis through screening, to reduce the cost of the morbidity and complications, and overall, ultimately to reduce the lack of productivity and the burden that diabetes has on Kuwait.
So Dr. Naila, your society will be key actually in gathering some, at least, of the data that we need to move things forward. Dr. Hassan, can you just introduce yourself, please? I know you don't need any introduction. And then tell me what really do you think of what's going on? Let me just give a slight statement. In 2004, we had a conference, and Dr. Mohammed Jarallah was, I think, the minister, and I said in 2004, I really predicted that diabetes will drain the Ministry of Health, and that diabetes will bring the economy to its knees. I didn't have any models or anything, it's just in my brain for simple calculation. And it turns out to be probably correct, or so, if we do not really take immediate action. So, given this, so please introduce yourself and tell us, how do you think we can address this problem, if you have a chance of doing it, or if you have the power to do one thing, what would you do? It's a difficult question, but introduce yourself and tell me, what would you do?
What will I do to reduce the burden of diabetes?
Let's say you are the policy maker. You've heard today what's going on. Part of the problem, and I'm going to raise with the audience, is why don't where's the data? Right? So where is the data? I want you to be a little lively and friendly, and let's talk about this. Otherwise we'll all be shy and all this. So please introduce yourself and tell me, what would you do? One thing you would do.
Okay. Assalamu alaikum. I'd like to thank you all for inviting me first to be part of the panelists and to share this experience with all of you. My name is Dr. Hassan. I'm a pediatric endocrinologist to start with. and I'm currently the Vice President of Kuwait Diabetes Society and the Head of Population Health at Dasman Diabetes Institute, and I'm also Head of Pediatric Department at Harani Hospital, MIH. So I wear the three hats, the DDI, MIH, and KFAS. To answer your question, I think to reduce the burden of diabetes, then you need to reduce the number of people affected with diabetes. We're talking, in the presentation, we're talking about the preventive measures with regard to preventing the complications. I think we need to focus all our resources, all our effort, all our researches to prevent the occurrence of diabetes. I'm not talking about type 1 because type 1 is very difficult to prevent, and no research has proven the still is carried on to see how can you prevent or delay the onset or prevent the progress of the diabetes. We're talking about 2, and we know type 2, big part of it is related to your lifestyle, to your weight, to your level of activity, to the other risk factors, to the smoking, which are all preventable factors. So if I have the power or the to force something to be done, is to prevent diabetes. Prevent diabetes, I mean at all levels.
How would you do that?
How would you do that?
You have, yes. Just one thing that you think we should do.
Prevent obesity.
Right.
Prevent obesity, encourage exercise, and it should be from the start, from early on, from childhood, from schools.
How would you prevent obesity? Would you put a taxation, for example, like the Japanese do? Anybody who's above BMI of 30 will pay.
I think you need to change behavior. Change behavior, educate, and start that from the kindergarten. Follow up these kids, teach them. I mean, not encourage them, but let them be raised.
Education.
Raised
right.
in a well-mannered way of living their life with regard to their level of activity, to their food. Teach them and keep an eye on them till they graduate, because the obesity will occur at the pubertal age. So if you give them all the tools, so when they're 18, they're mature enough, they have all the tools to take care of their health.
So you want to push education, that's your tool?
No, together with the legislation.
Yes, of course.
Together
so
with all the measures.
Right.
So but you have to start from early on and put it as a whole project.
Right.
You do not fractionate. What we do in Kuwait, we fractionate. And we work in isolation. And we target subgroups. We don't target the whole community.
Right. Thank you very much. Hold that thought for me. Dr. Mohammed Al-Khamis, please introduce yourself, and I'll give you your question later on. Please go ahead.
My name is Mohammed Al-Khamis, and I'm part of Kuwait Institute of Scientific Research. Soon I'll be joining officially the Faculty of Public Health at Kuwait University, Department of Epidemiology and Biostatistics. I'm an epidemiologist, and my specialty is principles and methods, quantitative methods specifically, and I focus all of these things into surveillance systems.
Thank you, Dr. Mohammed. What is the problem? Why are these numbers so vague? What's the rate? What's the prevalence of diabetes in Kuwait? What's the incidence? I can tell you very clearly of the incidence of colorectal cancer in Kuwait. It's 14 per 100,000 per year. I can tell you exact numbers about other things. Why is the... Yeah, well, this was a technical question. This was a technical question, which absolutely right. What do you think is the problem?
Well, honestly, I've been screaming about this problem for years now. I mean, the problem here is that we don't have a surveillance system.
Yes.
It's just as simple as that. You know, there is no surveillance system, and the reason that we need a surveillance system is because we need to estimate the baseline risk. So when you even say the burden of diabetes, and we have this incidence and prevalence, especially the incidence, I always question myself, what's the baseline? You know, do we really have a baseline here? We don't, unfortunately. We don't have, as Dr. Zahra said, you know, we don't have a registry, we don't have that. So based on this, all of these numbers that they have been presented, if you ask me about my true epidemiological opinion, they don't tell really the story, and it's very, to me, dangerous that we want to use policies and things based on these numbers. So in order to achieve proper control and prevention, in order to have proper estimates of the burden of diabetes in Kuwait, we have to take seriously to establish a mandatory surveillance program in which we can estimate the baseline risk, in which we can calculate the annual expected number of cases, in which then, if we have, and we can set a threshold for that expected number of cases, and then in the next upcoming years, we can know if there is an increase in the observed number over the expected number, in which we can say, okay, diabetes is reaching or exponentially, increasing in that term. And this is where policy comes. And I'm talking that because there are obvious experiences around the world, like the CDC, they have a very vigorous surveillance program. You can check their websites for diabetes, and in which you can, ultimately get a valid prevalences or incidences in that, sense.
So here's the figures from China. China grew in 2011 at about 12%, the gross domestic product. Diabetes in China is takes 19% of the gross domestic products. I hope because that may correct me, but this is a recent paper. So they realized only by literature review that we have a problem. The question also to you, if I may ask, is why is there a lack of published papers about this problem? I mean, where are the research? Where is it?
You mean in Kuwait?
In Kuwait.
Yeah. This is a tricky question, actually, and it's a political question as well. I mean, honestly, the only institute that shed hope to me is Dasman, when I hear that there is a first cohort study that's been conducted. Oh wow, that's interesting, because I've never seen Ministry of Health doing cohorts or case controls or all of these things, and the lack of publications, because we are not serious about establishing proper epidemiological studies, which is the core foundation of publishing valid scientific point of view. Here we are accounting for plenty of confounding variables, biases, rigorous statistical analysis. All of this is required proper, data, and where we can collect proper data from doing different classical epidemiological study design here, and we need and the thing is, there is a lot of issues also with funding, especially, I mean, the Ministry of Health should really focus on their budget into allocating a lot of money, not just for other foundations like KFAS, but they really have to invest seriously in funding such studies within as well as different government entities, okay, like the Public Authority for Food and Nutrition and all of these things. They have to invest a lot of money in this in order to achieve serious solution, in order to generate proper inferences to be published worldwide.
Thank you very much. Dr. Abdullah Sawah, welcome to the session. Please do introduce yourself.
Good morning. My name is Abdullah Sawah. I'm a PhD student in the field of health economics. I would like to start with thanking KFAS and DDI for organizing this seminar and for inviting me to be here with you. Special thanks goes to Dr. Zlatko and Professor Fahid for this excellent work. I cannot emphasize enough on the importance of this work. From the point of view of health economics, we can predict that our healthcare system is going to face a very critical challenge in the coming years. So, in diabetes itself, we know that from the literature, more than 40% of hospitalized patients were diabetics in 2011. And diabetics were hospitalized 2 to 3 times more than non-diabetics. We know that we're expecting that the Kuwaiti population of 60 years or above are going to be more or about 25% of the total population in the coming 30 years or so. We know also that health expenditure due to diabetes in the MENA region is going to increase from $13.6 billion in 2013 to around $24.7 billion in 2035. And since Kuwait has one of the high prevalences of diabetes in the region, a big chunk of these funds are going to be provided or paid by Kuwait. We also know that more than 85% of health services in the country are provided by the government. And since the government relies on returns from oil exports, and given the global prices of oil and the increase of diabetes in the country, we are going to face future challenges. So we need to find solutions both in health system reform, but also in the control of the increase of incidence in diabetes.
As Dr. Amali al-Battah, which I did not thank you for organizing this, and my apologies for this, but you're key really for all this, stated very rightly, any policy making should be based on evidence, and evidence-based. So do we all agree there is a lack of evidence? And if we do that, how do we correct this? I think I'll go back to Dr. Hassa al-Kandari, because really Dasman putting on a new heavy metal jacket to actually push through an unbelievably impressive effort led by Dr. Qais Doueri. We are in the trenches. I mean, we are here in the trenches. I'm telling you, we're here 6:30. We leave 7, 8 o'clock at night. We realize the problem. We know there is a problem. How did Dr. Qais and Dr. Hassa, how did you had a vision. I wasn't part of it, but you've done something, and I came from the outside and I looked at it and I thought, this is the magic bullet. Talk to us about the registry a little bit, please.
As was clearly mentioned by Dr. Khamis, that we don't have baseline data, we don't have simple epidemiological data. So we started simple by collecting epidemiological data and tried to address the diabetes from the pre-diabetes stage till the outcome. Doing that by several projects. We're planning to do screening for the pre-diabetes, so we can capture people even before the diagnosis. We know that type 2, you can stay for 8 years silently without being diagnosed. And then we're trying to get data on those who are diagnosed with diabetes, and we're trying to link that to their outcome, which fits very well with the study of the economic burden of diabetes, because as the doctor was mentioned, that whatever was presented was based on self-report. So we don't have any actual records of the data. We don't have the actual cost, because whatever was referred was based on self-report, which is, we know Kuwaitis tend to forget even their medications, so they will never recall how many times they were admitted in the past 1 year, why they were admitted, to which clinic, to which hospital, because we know the level of care is actually separated, like primary care cost is not like secondary care cost, it's not like tertiary care cost, so you need to get all these accurate data before you can estimate the cost. So what we have planned is to launch the diabetes registry, so we can register all and single patient with diabetes. Now we're talking about the core of let's say that spectrum of diabetes. So we're talking about those who are diagnosed. We want to record all these patients, all ages, all forms of diabetes, including type 1, type 2, pediatric, adults, and gestational diabetes, and also rare forms of diabetes. The registry will be populated by all diabetics. We're trying to do so by getting solid data from the primary care centers, from the secondary care level, and then we're going to attack the tertiary care level and include the private sector too. We're going to link that by building the software, building the template, where the physicians can feed in that template and making that obligatory, so we can get the crucial data as by obligation to be filled in for all diabetics. And then we're going to link that to the مركز الوطني للمعلومات, which Dr. Abdel Ajib will be there, and his group. To the mortality and morbidity, we'll be getting the inpatient data and all the outcome data. Now we're at the state of preparing all that, preparing the software. We got all the political part done. So the team were formulated. We had the approval from the MOH at higher level, at the minister level, and at the undersecretary level, thanks to Dr. Qais. The group is formulated. Now we're building in the software. We're linking all the data, and we're starting the pilot at 1 governorate. Maybe in the coming 2 years, we'll have that data as evidence-based linked to the outcome, mortality, and morbidity, and then we can estimate the cost at least from the what we get from the Farwani, and of course, Kuwait Diabetes Society is included, and the primary care center is included.
What's the timeline you think that we may be able to deliver this? Because timeline is critical. I gave Dr. Qais a timeline of 2020 that we're going to make something major. I know we have amazing researchers here, and the administration is extremely supportive and democratic and amazing. What is your timeline? You know, we would like it to really be available to everybody, so we can know what the problem, the size of the problem.
You know, I'm not young, Dr. Fahad, I'm more staff, so I know things in Kuwait will take longer than usual. So when we planned the project, we planned it in a realistic way. So we gave 1 year for preparation, because I've been running for getting the people to be on the table for 1 or 2 months to call for 1 meeting. So I know that. So when I planned that project, it was very relaxed way, so that to be realistic. So and 2 years for the pilot study at Farwani Governorate. So to get the results from 1 governorate, we're expecting that to be in 3 years' time. Once you start the model, then you can implement easily. So we expect the inclusion of all the governorates to be completed, inshallah, in 5 years. 5 years.
5 years for this to complete. I'll tell the ISAP this. So the ISAP is the
you have to be realistic. You know,
yes, you're absolutely right.
Yes, otherwise it's not feasible. If you plan something that's too good to be true, then you'll be aborted in the middle of the project because you have not progressed.
One thing is important. Major discoveries that happened in humanity happened when there was war or pressure. It didn't happen when you're relaxed and enjoying yourself. It's only when you're under pressure. And let's really learn 2 things from this. Is to push forward. We need to be, and I like the ISAP because they love to put us under immense pressure. So next time we will tell them we'll finish it in 2 years, inshallah, with your effort. Hopefully.
It will put a lot of pressure under MOH, but
right.
They need time.
Yes. So we'll do that. I'll open a little the floor to the audience if they have any itching questions, please. Yes.
Dr. Ali Al-Dibi, a diabetologist and academic clinician, recently joined the DDI from England. Thank you very much for the event today and for the panel. I second your opinion, Dr. Hessa, about education, and I think it's very important. And why not integrate it into the curriculum, both in government schools as well as private schools, that dictates at this early stage what is healthy living is, both in terms of nutrition, both of physical activity, smoking, and so on and so forth. The other day I was driving, and for 1 second I took both hands off the steering wheel, and my daughter shouted at me, said, "Why, Daddy? You should keep your hands on the wheel. My teacher said this." So students learn from their teachers, they respect them, they are very inspirational to them. I think if we hack into this and make it part of the education system. That will pay off in the future, certainly.
Thank you very much. Given the education and its importance, there is something we have to be very careful with. I usually hear this: if you don't have hypertension and if you don't have diabetes, you're not Kuwaiti. And this is a very dangerous statement that I usually hear. Are the people saying diabetes is okay? Do they understand the economic burden as a family? Do they actually understand the loss? I would like to open this, to Dr. Abdullah first, and then we move across to Dr. Zlatko. Dr. Abdullah, do you think that people understand because it looks to me they're saying it with, it's like it's okay to have diabetes, it's not a problem, and hypertension.
I don't think the public are aware of the burden of diabetes, and that's why I emphasized on the importance of this research. But I think another challenge that faces this research in the future is basically disseminating the results of this project. I know a lot of, not a lot actually, but quite a number of papers were published on diabetes in Kuwait. But the findings were not disseminated, neither to the public nor to decision makers. So I think us as researchers have a responsibility as well to try and find bridges of communication to actually convey the messages to decision makers as well as the public. I know our decision makers are overwhelmed with mostly political struggles, but we have to be more persistent and we have to keep on trying.
Dr. Mohammed, what do you think about the public and what they think about diabetes?
Yeah, so from perspective, so one of the alternate things, like when we conduct an epidemiological study or a surveillance system, the idea is to provide inferences in which you can make decisions, policies, and then you do start education and outreach. So basically, because we lack in this, it's impossible to do proper education and outreach to the public. So basically, it's by far, I would say, the problem comes with us and the stakeholders, in which they don't have, and they will, I saw many campaigns, many stuff like that, but because we lack the evidence base, the data, the studies, it's very hard to do proper education and outreach. And also there is another problem, risk communication. We are lacking this, communicating results to the public also. Even with an epidemiologist or, whatever, part of the research team, if they are involved into delivering or educating the public, they also have to have a good understanding of what's risk communication. And it's a big topic, but that's always a part that we need to emphasize when we talk about diabetes as the next epidemic it's the epidemic of the century now.
The first thing really when I spoke at length with Dr. Qais about this, he says we need visibility, we need to reach the public. It's good to sit here and say we have a biomarker for diabetes. Do people understand that? So we're pushing through, it's pushing through hopefully visibility through the mother company of Google.
Yes.
And that's very important.
So one small point, like one of the things our brothers in Saudi Arabia, they have the Center for Control, Disease and Prevention, and they provide public data.
Yes.
And they are updated everywhere, and they provide like very nice graphs, summary graphs and stuff like that, and it's accessible to the public.
Yeah.
And I think that's also that's part of the visibility that you are talking about. Yeah.
Right. Yeah. Dr. Hassan, you think this is extremely important? Yes.
Yes, I totally agree that maybe we're not doing our job as we're supposed to do to disseminate all
you see, this is not our job. This is the problem. in my opinion, it's not really our job to go to the public. The NIH was a locked-in place where the research was done in a really amazing, prolific way, but never communicated out. And I was surprised, my wife nudging me and says, oh, there is a study of certain gene that happened, blah, blah, blah. And I said, oh, where did you get that information from? I got an email from the NIH. So the NIH now is targeting the normal people. It's not the job of a researcher to do this. It's the research of the public relations, people who are dedicated to do this. And I think we do have, I mean, correct me if I am wrong, we do have in the Ministry of Health huge public relations and all this. It's just, and forgive my impulses and my straightforward thinking, we all need to be pushed to do things. So, yeah, maybe we need to push, yeah? So, do you think, because you have maybe a different point of view, you think the researcher's part of his job to translate this to the public, do you think?
It's not to the public. Even we do not disseminate the knowledge to our colleagues.
You're right.
Then if you search, like you search money, then you see the number of publications that I have. I never tell you like, oh, I have this paper, just see the work that we had in our department. So, like at KDS, we're doing all these campaigns, media at MY doing campaigns, primary care centers are doing campaigns, but we tend to do all these campaigns with the World Health Diabetes Day. So it's in November, everybody is active, and then we go and sleep. And it's like personal, again, it's personal effort in isolation, primary care center separately, MY separately, we do our work separately, we do not collaborate. To make that campaign continuous, doses every month, like use all the methods that you have, all the media ways. No, we just have an idea, we execute, and then till next year.
Persistence.
Yes, and it has to be.
If you learn anything from the McDonald's business model, the only way they succeeded was because they were persistent.
Yes.
This is so persistent.
And they had planned it well.
That's right.
But
So
people, it's not a
persistent.
planned thing.
Yeah.
We sleep and we come up, we have an idea and we get up and conduct.
Okay, so we have one question from the audience. Oh yes, so, please, go ahead.
Sorry. Shukran. Thank you. Thank you for an amazing seminar. Thanks so much. Every time somebody says something, I say, oh yes, I have to say this. But we at the Public Authority of Food Nutrition, and before that, I've been in الصحة. For years I am there, and what made me reach where I am now is the Ministry of Education. Ministry of Health. And that's why I'm in public health nutrition, and this is where the weakness is public health. Public health, the whole efforts and budget is all going to treatment. We take it backwards, public health. That's why prevention is very important. And the School of Economics was here 3 weeks ago, and for the past 5 years they were saying the same thing. Don't build more hospitals, invest in public health. Now, I want to just raise up one issue with regard to what Dr. Hassan was saying with regard to intervention at an earlier age. And you can speak so much about this life cycle, you can talk about the breastfeeding, you can talk about things. But we have a very important and very feasible and attainable intervention, a setting that is schools. Haram, what's happening to our children. We can do so much with the curriculum. We've been saying this for a long time. So I remember as far as 2006, Minister of Health, then was His Excellency Mohammed Al-Jarrallah, and it was the strategy for physical activity and health, DPAS strategy. And we put down a plan and related sectors. There were more than, and Dr. Qais was there, more than 12 sectors there. We have to work together, even for education, with a plan, measurable plan, to know where we're going. You can do it. Now we are 2019, that's 13 years ago. Imagine if we had succeeded in one thing, only the curriculum. Now, if I talk about the canteens, we'll be here all day. And I'm saving this for the next session because of the sweetened sugar data.
But why did we not succeed? Or do you see it?
The priority is not there.
But why did we not succeed?
Because nobody's willing, you know, as Hassan was saying, everybody gets excited when the committee was established, and then we got into a lot of complications and everybody went back to their desks, and it was forgotten. Another system that is existing in the Ministry of Health is the surveillance system. It's a WHO project. You start with small indicators to be measured, and then if you don't expand, because it shows you trends, it showed us that diabetes is going up, physical activity is going up, but we don't expand and do the appropriate and related research to expand on it and see where the problems are and how can we make it better. Our children are very important. Now it's 13 years, whoever was 10 years now is, you know, with us.
Back again to evidence.
Thank you.
So we need the data. Yes, please. The document, please.
First of all, thank you for the invitation. My name is Ahmed Al-Sadi. I'm an assistant professor of genetics and behavioral science from the Faculty of Medicine. I agree with Dr. Nawal in terms of the involvement of the Ministry of Education. But I mean, that's not, it seems that we're too focused that this is an issue from, stems from the Ministry of Health or DDI. I mean, we have to really think about that Ministry of Education, Ministry of Commerce, Ministry of Housing, all those ministries, all these stakeholders are actually involved in the issue of obesity and diabetes. I could give an example on each ministry how they are involved actually. So until they acknowledge that they have a role to play in all these issues, then we could actually get forward. I mean, we were just too focused on the Ministry of Health being the reason behind this, but all these ministries actually have a role to play.
Extremely important point. I remind you, we had I think a few years ago, a kind of collaboration between the Ministry of Health and everybody, even the Ministry of Interior, even the Army and all this, and a project called Kuwait Energy Balance, which was going to be headed by KFAS. And it was amazing because we also looked at why the roads are engineered this way. And I went back to my family, which is Al-Mullah, and of course he looked at me and with a smirk on his face, and he says, "My friend, my dear, we wanted to make sure, don't go tell them this, we want to make sure that everybody drives, not walk, because we want to sell cars." So how do you feel, how do you feel in a really business kind of led economy, such hard decision as closing McDonald's or this? This is radical, you cannot do that. And so we have to really, think about things. Yes?
Assalamu alaikum. My name is Noura Sharida. First, I'm a dietitian with an MPH in epidemiology and biostatistics. Actually, Dr. Mohammed Khamis برد كبدي in Kuwaiti. But still, I heard so many ideas, so many people saying about studies, but still we are not focused. This is what I understand. When they mention about the registries, okay, how you will implement the registries, how you will evaluate it, how you will do it in a probable way for Kuwait, for the ministry, and not for just ministry, for all health sectors in Kuwait, because we didn't study our population yet.
Yes.
This is what I understand. And as freshly graduated, but still I want to do a study. I'm struggling with studies because why? Because we don't have registries, we don't have, it's all paper-based.
We're struggling with you. I understand this, but now there are serious efforts to put this
But
forward.
even if we want to do a cohort study,
yes,
we first have to implement a good registries for all diseases.
Agreed.
And we don't have a biobank. I heard there's a for diabetes, but
Right.
what about the other diseases?
Right.
And for the cohort study, my last point, there's a new way to start with like Mendelian randomization.
Yes.
It's a good way to estimate the causes here happening in Kuwait, why this disease increases?
Well, Mendelian randomization is a genetic
Yes.
ideology whereby samples are randomized automatically
Yes.
by nature. We understand that very well about this, but I think let's not sophisticate it. Let's go back to basics.
Yeah, which is the registries.
Let's work together. Let's work together, because that was always the problem with us. And I want to be frank here, you know. And I don't know who Frank is, but I want to be frank. That's okay. Let's always, and I came as an outsider. I looked at Dasman, and it was in silos, everyone project and all that. And very quickly, the wise democratic management changed that into 1-2 big projects. That we are all working together. And I think the spirit is really high at Dasman at the moment. This is what we're going to do. We welcome you.
Thank you, but
to
what
join
about
us.
other diseases? This is my point.
Right.
Yeah.
Now, let us, for Dasman, I would really like to solve diabetes first, because they hired me here. So we want to do that first. The other diseases is, let's tackle one at a time. Other diseases, this session is only about diabetes and its complications, and I would like to keep it this way. So you have double of the time, Dr. Zlatko, to stay as a diabetic. You stay double the time in hospital. If you have more complications in your populations, you have a problem. How would you, if I tell you now, because we really have only started. I mean that's really only the start. What can we, as all together, give you and us? What would you like to have to produce one of the most brilliant studies in the area? What would you like? You have this magic wand now, and you will say, I would like to have this, and that, and then I'll produce for you, or we produce together.
Yeah, just as I said at the end of the presentation, if we have the total number of inpatient admissions, which happened, let's say, for 1 year, for last year, 2017 or 2018, including all diagnoses which were attached to the inpatient admission, I think this would be sufficient to estimate the admissions due to diabetes.
So why didn't you go to the ministry, or, and there's a statistical department there in the Ministry of Health, and tell them, give me the, I have this study I'm doing, give me the data, please.
Yeah, we should request it. Obviously, there'll be some problem with anonymization, because I guess patient names and addresses will be still on the records, but obviously we have to request it, anonymize it, and then have the information. In addition to the inpatient admissions, I think all the outpatient visits, which happen in outpatient centers, but also in the primary healthcare centers, I think it would be useful to have that as well, because a lot of diabetic patients go to see a doctor because of follow-up visits, to get prescriptions for insulin and so on. So I guess there is some cost attached to outpatient visits as well. So we would need that as well.
Yes. In your model, did you consider the more expensive drugs we are thinking about now, GLP-1 agonists and sodium glucose transporter inhibitors? These are extremely expensive. Are you going to put this in your model?
We should contextualize it, obviously. Yes. I mean, if we have the Kuwaiti context, we have to include all the drugs which are available in the market and which patients use. So yes, contextualization is important.
Dr. Hissa, please, you wanted to comment.
I think you'll get all the data in the National Information Center at MOH, but you will struggle in one thing, that the way the doctors are writing the cause of admission, or even when they discharge the patients, we actually will not help you, because we tend to write the cause of admission like MI. Then you're not sure is that patient diabetic or not. Or we write CVA. We do not list the problems that the patient has. He has hypertension, he has diabetes, and he has. To get the accurate data, First, you need to visit that center and see how clean their data are. They do the ICD coding. They do have all the data. They validate. They go back to the records. But it's the problem of the physician. So for the future, I think if you want to implement that project properly, we need to educate the physicians to write in a way that we see diabetes in all the admission. It should be an obligatory.
Yeah, this is why I mentioned the Qatar example. I mean, there they have 38 diagnoses in the discharge. So diabetes could figure in any of these 38 cells. So we took all the admissions where diabetes appeared in one of these 38 cells, regardless whether it was the first diagnosis or the last one. So that obviously gives us a much better picture. Yeah.
And Kuwait is not obligatory.
Right, so education is important, but I think you need to look at the UK system where the physician but they need to enter it electronically, and they cannot enter it in the wrong way. So they only have to do it that way. So they are forced to enter it. So you have a system, yes.
Yes, in Farwani we're forced to enter, but then you can select what to enter. يعني أنا ممكن أكتب أي شيء who will check out.
Yes, in the UK system you cannot.
Yes.
Right, that's what I'm saying. So you force the physician, you have these options, or do that. Yes.
Dr. Fahid, I just want to add, this actually might be easier to do in the private sector. Because of the insurance there, if a patient does not have diabetes on the diagnosis, either final discharge or admission, they don't get the diabetes medications. So in the private sector, all the diagnoses, diabetes, hypertension, anything that they're getting medication for has to be mentioned, but unfortunately, because healthcare is free of charge in the Ministry of Health, there is no obligation to actually put these individual diagnoses. So what we want to do is make the Ministry of Health, be the same as the model in the private sector without the insurance part. So
insurance is really important. Again, Dr. Zlatko, what was your major challenges doing this?
Well, we still are facing a lot of challenges. So as I said, now we are doing the logic model on a patient and outpatient utilization. And we're still struggling with that because we can't find a model with predictive capacity which is good enough to pass the threshold. So we're not happy with the estimates yet. So that's the biggest challenge at the moment. So we're trying a few other things, and hopefully something will work in the next few weeks. But for the time being, we don't really have an estimate on the link between diabetes and utilization based on the WHS. It could be a problem with the survey itself. It could be a problem that we're relying on self-assessed diabetes. We're not using objective measure of diabetes. So this is why I think that coupling that exercise with administrative records would be important. It's an imperative, actually.
Thank you very much.
Dr. Fahid, I enjoyed your moderator skills. I'd just like to make a statement that is diabetes is a very, very, very serious disease. And most of the people, even learned and educated people, don't realize that. There are epidemics that are, short-term epidemics, cholera, Ebola, etc. They can be treated. But diabetes is a continuous epidemic, and especially in Kuwait. And people don't realize it. DDI needs funds. KFAS doesn't realize it. Unfortunately, they decreased our funds. Now, in short, to try to solve this very complicated problem, there are long-term solutions and short-term solutions. Short-term is to try to decrease the complications of diabetes. That's draining the Ministry of Health. I estimated, I don't have the figures, but nearly 30 to 40% would go on all the diabetic diseases, because it affects every organ, not just the disease itself. And therefore, I agree, it should start with education from very, very young age. That is very important, that we educate people to the risk factors and how you can prevent diabetes. The other thing is It's proven in research that if you change your lifestyle, in obese people, diabetes is cured. And the other, this is where education comes in. So you change your lifestyle and, you do exercise, you eat properly, don't get obese. So my request is to KFAS to think of this as a very serious disease and try to concentrate on funding DDI more. Thank you.
Thank you, sir. Thank you for this. Yes,
thank you for the nice presentation. And diabetes is a real burden. I would like just to drive the issues. Diabetes is not a health issue. We should change it. It's a nation issue. If we can change this concept, we have to have the high political commitment. You cannot work alone. Of course, if you have an excellent epidemiologist and excellent surveillance system, and you have a lot of outreach, and you can do a lot of educations and other maneuvers, still it is a high political commitment. If you don't have a multi-sectorial involvement, it's not a Ministry of Health. It's many sectors in the government. If you can't get them involved, and it should be a sustainable program, and you should mobilize, and as Dr. Ghar said, you should invest more. Why we're investing mainly in the clinical practice, in the therapeutic and the curative. And unfortunately, I came from Ministry of Health, and when I was, led the public health divisions, I was really surprised that we don't have that much, with all respect of, the expertise there, and who's doing his best, but we don't have, that expertise in that field. Unfortunately, the Ministry of Health was really keen, to look for many educational institutes, to train most of our doctors, but not in the public health. Unfortunately, it's many subspecialties, and we have an excellent, graduate, and we have excellent. But still, the public health, we have to invest more. This is a main issue, a main gap in the, I'm talking about Kuwait and even in the GCC. Because I was representing the US professor at the Ministerial GCC Council. Still, we are not focusing on that. And even the public health, they should, have, a decision. They should be, one of the decision maker at the high level, not, what's going on now in the Ministry of Health. So, political commitment, mobilizing resources, and also, Dr. Hassa, I'm not with you. I'm really optimistic that the Kuwait National Diabetic Registry, it will, grow fast. We met with Dr. Hal, the minister, Dr. Basel Sabah, and Dr. Mustafa, and they are really keen. And we told them, this is your now. You have to, adopt. During Dr. Awad's era, minister, he adopted the cancer registry, which is an excellent registry. So this is your era now. You have to put all the effort, all the resources, and we have to make it as serious. It's a priority now. There is no time to be wasted, We should focus more to have, a very competent, reliable registry. And not only diabetes. Diabetes is part of the NCDs. It's part of the 4 common diseases. That, this is the way, to prevent. There is a whole declaration that was at the UN in 2011, and Dr. Hassan was there, and they declared they have to have an action plan to tackle the NCDs and the risk factors. So diabetes is a major part of these diseases. So if we talk about diabetes, we cannot isolate the other common diseases or the non-communicable diseases because part of the issue. So I don't think we have to have it in that. If we succeed as a technical team that to raise the issue to the higher level and to make it at the national level, I think this is the early phase. You can see the light at the end of the tunnel. But what we are doing now is fragmented effort. We are doing some few good, but still it's not at the national level. Thank you.
Can I add just to your point, Dr. Qais? Just one thing.
Hold on.
Yeah. Adding to this, we need law enforcement. I'm sorry, it sounds radical, but if you go to the United States, you go for entities not sharing information, not providing it to government entities, it's considered a crime. And when there is an established surveillance system in which forces other government entities to provide data, to participate, and even companies, if they don't provide, if they don't do it, they're going to be criminalized. So it's a serious national issue in which people are dying, our children are dying. And if we don't have law enforcement and collaborate, then I don't think we're going to be succeeding.
Thank you very much for really the wise words we had from Professor Hilal and Dr. Really well. Dr. Amani, please.
Thank you, Dr. Hilal and Dr. Qais for their comments, and I shall not comment on KFAS's lack of funding. We're sitting in a KFAS center. But I wanted to take your attention back to the moment when Professor Zlatko asked for a bottle of water. And it took about a minute and a half for him to get that. Why? Because we all depended on other people doing that job, and it took us that long to get a bottle of water on the podium. They call this a bystander phenomenon, where each entity looks at the other one for the responsibility of doing a very simple job that if they had done it, the problem would have ended at a very early stage. I think a lot of the policy issues in Kuwait follow the same kind of pattern. We say, MOH should do this, Ministry of Education should do that, the political decision should be made, what have you. But if a team of dedicated people start something and they do it perfectly and they do it as an exemplar, then everybody follows. That's Merrill Lynch, I think, motto, if you build it, they will come. And I think a part of the lessons that we learned from the discussions regarding healthcare reforms, the Health Act legislation, is that a very small number of people, it wasn't really a large group, it didn't require a lot of funding, it didn't require a lot of high-level political decision. A small group of people sat together and they decided that they're going to talk to everybody who listened to them. They're not going to keep it behind closed doors. They're not going to depend on somebody else making the job, getting the job done. They will do it, and they will contact everybody who is relevant to this, and then they will have the widest possible dialogue. And this is what we lack in all of these things. First, taking their responsibility, taking on the mission, and second is talking to everybody who is relevant to the task. And if we do that, the education is a byproduct of the very activity. The sense of urgency becomes a byproduct of the very same activity. And the product of the small team that begins, so the registry for diabetes or the awareness programs or what have you, if we start one thing, just one thing, and we do it well, and we do it as an exemplar, then everybody follows, and then everything falls in place. So I think that the number one issue is the fadila. And until we get that, so we're not going to wait for 3 years until we get proper policies. Until we get that, we're going to use proxies, as Professor Zlatko has suggested. So whatever data we have now, we should use it and then propose ways to estimate the cost. We have the proxy data and we can't have estimations. We'll use estimations until we get the proper thing. So we're not going to wait until that is done, until a political decision is done, until whomever takes whatever responsibility. We have our own responsibilities, and I think with the proper and motivation, I go back to what Dr. Fahed has earlier said, we need to be under the fire all the time, because that's really what produces results.
Yeah. Thank you.
Thank you. Just a small word, Dr. Fahed. We are very, very good whenever there is any problem to give solutions, and we know exactly what to do. We are very bad in actions. Now, I think this very serious diabetes problem is really above just Dasman, Kisser, the university. It's really a war, as you say, for politicians. Now, if you want an action, I think we should form a committee from KFAS, from Kisser, from university, from DDI, and put a full plan. We know what to do.
Yes.
We know what to do, education, lifestyle, treatment, etc. Yes. And we go to the Council of Ministers, where all the ministers are there, and submit this very serious problem to them, stating the solutions, so that every one who's there can take action and solve the problem.
Absolutely. The decision always has to come from, yes, the decision always has to come from the top. Yeah. And then we need to deliver. That's the motion. We have one question from Professor, I forgot your name. Harry. Yes. We are 1 minute behind, so let's...
Okay. Thank you. I'm going to be brief. Since I'm coming from the Faculty of Public Health, and therefore I'm a believer in prevention. And I think that, as was pointed out by several speakers before me, actually we know a lot. And we know a lot behind what are the causes. And we also know that what are the causes of the causes. And I mean, it is not only an epidemic of diabetes or type 2 diabetes today. I mean, we have previously had an epidemic and still going on, epidemic on overweight and obesity. We have an epidemic in physical inactivity. And there has been a huge change in lifestyle in Kuwait within the last 30 years. So I think that all these things actually explain much of the disease outcome today. Diabetes being one, but just one, because there is also cardiovascular diseases. There are the diseases of various kinds of cancers which have an increasing trend. And instead of trying to have a specific prevention program for cardiovascular and specific for diabetes and so on, perhaps one should look for the sort of specific NCD prevention program, because many of those diseases have a joint sort of causal factor. So you can influence by having an early sort of prevention program on the determinants of these diseases, and then you can actually have a much better outcome with your KDs available. So thank you for this discussion. It was delightful.
Yes, I want to close this session. I would like to thank you, the audience, for coming here. I would like really to thank KFAS for sponsoring this. This is exceptionally important for us. We really love you a lot. And thank you, Dr. Faiz and Professor Bilal and the panel. I really thank you very much for coming here. One big
Thank you, Dr. Fahad. Thank you, panelists. We will break for 15 minutes. We have an equally interesting topic after the break, starting here in 15 minutes. Hoping to see you then.